How's everyone doing? This is Luke Tomich from the Epilepsy Institute. I'll tell you about two cases that we recently did that are quite interesting and quite novel for New Jersey. We recently operated on a young lady who had left temporal lobe epilepsy. This, based on WADA and functional MRI, we felt that her left temporal lobe was her dominant temporal lobe. And we started with an SEG implantation, and in the posterior temporal region, we were able to stimulate through the electrodes and provoke her typical seizures, but stimulating and provoking her typical seizures also led to speech arrest. So we felt that likely this posterior region was not only responsible for seizure onset, being part of the epileptogenic network, but also in what we call Wernicke's area, speech area. And so we knew we couldn't resect that area without causing a unacceptable speech deficit. So what we did in this case is a anterior temporal lobectomy, including the mesial structures. And in the same surgery, we placed electrodes over this posterior temporal area and connected those electrodes to a neuropace stimulator to be able to try to treat whatever residual seizures would come from the posterior temporal region that we felt was eloquent for speech. One of the other cases that we did just a couple of days ago was a repeat hemispherotomy for a patient with something called hemispheric atrophy in the setting of polymicrogyria. And this is a difficult to treat epilepsy because polymicrogyria can be a diffuse process. This patient underwent, unfortunately, several epilepsy surgeries. She's a little girl. She underwent first corpus callosotomy. Then because she had a bilateral EEG initially, corpus callosotomy did lead to lateralization of her scalp EEG to the left side. She already had a right hemiparesis, which she was essentially born with from very young. She had a right hemiparesis. We did a functional hemispherotomy, and she had significant improvements for several months, but then had a recurrence and was back to having daily seizures again, unfortunately, after functional hemispherotomy. So finally, we did an anatomic hemispherectomy, which is still a very useful surgery that we do because in this case, you're not just disconnecting the brain, you're actually removing it and lifting it out. And she's doing great. Again, we don't add any neurologic deficits to this child because after functional hemispherectomy, you've already disconnected that hemisphere. It's functionally useless at that point. But there could still be some small connections and transmission of seizures to the good hemisphere. And so at this point, when somebody fails functional hemispherotomy, I almost always typically offer an anatomic to make sure that we've removed all that brain and there's no chance of a subtle connection.